All right. Good morning again. This talk will be divided into two parts. I'll cover acute ischemic stroke updates, and then Dr. Kaufman will do intracerebral hemorrhage updates. In this talk, this is just a picture for those interested of our hospital. But I'm going to discuss the epidemiology of ischemic stroke, new advances in stroke management. We're going to review aspects, but also posterior circulation aspects and TICI scoring. And then, of course, tenecteplase is a newer agent that a lot of hospitals are starting to use instead of alteplase in the treatment of ischemic stroke, including my hospital. And we're going to go over the importance of order sets, actually, in stroke care as well. So around 800,000 individuals experience new or recurrent strokes every year. 87% of these are ischemic, and in the United States, stroke incidence is actually going down in the US. Like less and less people are having strokes compared to years past, and they think it's just due to the advent of, medications, atorvastatin, like all of the other things that we're doing, aspirin. But by 2030, an additional 3.4 million US adults will have had a stroke. So how has stroke management changed? Stroke management has changed drastically in like the last 10 years. It's nothing like it was. Before, when a stroke patient came to the hospital, we would give them TPA. Other than that, there wasn't that much that we were doing. As a neurointensivist, there was a friendly battle between us in neurocritical care and those in stroke, because I would always say, oh, you just give aspirin and there's nothing else to do. But now there's a lot more that we can do. Endovascular thrombectomy is being practiced everywhere, even here in the DR. There's improvement in thrombectomy devices. Medical management has changed, and then also just prioritizing stroke workflows, because as we all know, time is brain, right? So educating the public, getting patients faster to hospitals, to the right hospital. Before, we would just take patients to like any hospital that had a stroke. Now emergency medical services, United States do not do that. If a patient has a stroke, they go to a stroke designated hospital so that no time is lost in the treatment of a stroke patient. And then also there are a lot of things that are still being studied, such as the role of thrombectomy in more distal occlusions, further out in our MCA branches, and also the role of thrombectomy in clinically mild strokes with a large vessel occlusion. So first I'm going to go over the modified TICI grade. TICI is thrombolysis in cerebral infarction score. The original TICI grade was in 2013, and this is the score that is measured after an endovascular thrombectomy has been performed, and it measures the degree of reperfusion. The current AHA and American Stroke Guidelines actually now have a recommendation as to what we should aim for when a patient undergoes a thrombectomy, and this is a TICI score of greater than or equal to 2B. And the grade is 0, which goes from no reperfusion, to 3, complete reperfusion. And the goal in our thrombectomies is now 2B, which is greater than 50% of the MCA territory that's reperfused. And this is still sort of like a subjective grading. I will say that at our hospital, we have 2 endovascular surgeons, and one is more gracious with his grading than the other, because it's just that you look at the scan, you look at the pre and post angiogram, and you're sort of just eyeballing it and saying, this looks like 50% or more, or 50% or less. So thrombolytics, as we know, like alteplase is an agent that catalyzes the conversion of plasminogen to plasmin, and it aids in clot breakdown. And it's essential for reperfusion in the acute phase of ischemic stroke. Alteplase was approved based on the NINDS TPA stroke trial that showed significant improvement in recovery when administered within this 3-hour onset window. And then the trial in Europe, which was ECAS-3, extended this time period to 4.5 hours. In the US, it's actually technically only FDA approved up to 3 hours, but everyone uses it up to 4.5 hours based on the European trial. And as we know, it's given as a bolus dose followed by a slow infusion. Tenecteplase is a newer agent that is a bioengineered form of alteplase. It has greater specificity to fibrin. It actually has a longer half-life than alteplase. And one of the big things about this too is that it's a single bolus administration. It is actually also significantly cheaper, even though it is a newer drug than alteplase. And there's greater ease of use in clinical settings. There was a trial at STEND IA-TNK that actually demonstrated higher reperfusion rates. I'm going to go over it in our next slides, and better functional outcomes at 90 days when comparing tenecteplase, which is abbreviated TNK, to alteplase. There are also 2 subsequent studies that have validated non-inferiority or superiority in various contexts. And this has led to a lot of hospitals moving towards tenecteplase. Do you use tenecteplase? Okay, yeah. So I am part of a 23 hospital system in Georgia. It's actually the largest hospital system in Georgia, and all of our hospitals have switched over to using tenecteplase and we no longer use alteplase, even though it's not currently FDA approved for the treatment of acute ischemic stroke based on the trials. I know, I think a lot of hospitals have moved ahead of the trials because the FDA is notoriously slow. Yeah. So I'll go over the first trial, which is at STEND IA-TNK. This trial looked at the efficacy and safety of tenecteplase compared to alteplase. And it was given, and it was looking at patients who received it before endovascular thrombectomy in patients with acute ischemic stroke. It was a phase 2 multi-center randomized control trial. And these patients were those who were going to receive an endovascular thrombectomy and had a pre-stroke modified Rankin scale score of less than or equal to 2, and were within that 4.5-hour window, and had a large vessel occlusion, either of the ICA or middle cerebral artery. Patients were randomized to receive either tenecteplase, which is a 0.25 milligram per kilogram dose with a maximum given of 25 milligrams, or alteplase prior to thrombectomy. And the primary endpoint in this trial, which I'll highlight, is just reperfusion of greater than 50%. So this trial was looking at the imaging to see if, the amount of vascular territory that was reperfused. The secondary endpoints were functional outcomes at 90 days using the modified Rankin scale, and also looked at, of course, with any thrombolytic, we want to know the rates of symptomatic intracranial hemorrhage. And this trial found that tenecteplase actually increased the rate of reperfusion. So this is just like radiographically. When patients received tenecteplase before alteplase, the reperfusion rate was higher, and it actually improved functional outcomes at 90 days. So it achieved both its primary endpoint and its secondary endpoint, and it had a comparable safety profile. So there did not seem to be any increase in the rate of hemorrhage compared to alteplase. The TRACE-2 trial was another trial that also looked at this, comparing the efficacy and safety of tenecteplase and alteplase. This one was not an endovascular thrombectomy trial, but just a trial. They came into the hospital and they got alteplase versus tenecteplase. They did not have to have a large vessel occlusion. And these outcomes looked at the primary endpoint as, this one was a functional sort of primary endpoint. So a modified Rankin scale score of 0 to 1 at 90 days. And they also looked at the safety profile being intracerebral hemorrhage. And this trial demonstrated that tenecteplase was actually non-inferior to alteplase and also had similar safety outcomes. So based on these trials, a lot of the hospitals have already transitioned to tenecteplase. The major motivating factor for any healthcare institution is often cost, right? And it is cheaper and seems to be as good, if not better, than alteplase. Endovascular thrombectomies have revolutionized ischemic stroke management, particularly for large vessel occlusions. We all know the Mr. Clean trial because that kind of changed everything in the stroke cure world in 2015, followed by other confirmatory trials like ESCAPE, SWIFT Prime, and others. And these trials all show that there were superior outcomes when patients had a thrombectomy over medical therapy alone in large vessel occlusion patients. Dawn and Diffuse 3 trials subsequently expanded our treatment window, right? So before, when after 4.5 hours, it expanded to 6, then 12 hours, but then Dawn showed us that up to 24 hours past the last known normal time, patients could receive a thrombectomy, and this could improve patient outcome. And these trials supported, assessing each patient individually. We became a lot more reliant on imaging findings to determine who would be a candidate for thrombectomy. And it also reinforced the need for the development of, protocols, including stroke imaging protocols and rapid triage systems, which is why now, based on all of these trials and even the expansion of the time window, if someone has signs of a stroke, they go to a stroke hospital. And we have 2 levels of stroke hospitals, primary stroke centers, and we have comprehensive stroke centers. Primary stroke centers can give, alteplase or tenecteplase, but do not perform thrombectomies, when comprehensive stroke centers can perform thrombectomies. And actually one of the requirements of comprehensive stroke centers now, which is good for my job security and future job security, is that they need to have a neurointensivist as well. Looking at, people have looked to see if, now in this world where we know thrombectomies work very well and patients do very well after thrombectomy and we improve outcomes after thrombectomy, do we even need to give alteplase or tenecteplase? Or if a patient is presenting, within that 24-hour window, should they go straight to the angio suite? So recent trials have explored this question. There was a direct MT and DEVT. They were both trials conducted in China, and they demonstrated non-inferiority of endovascular thrombectomy alone compared to it combined with IVTPA. So some people became very excited and said, oh, maybe we can just skip giving alteplase or tenecteplase and go straight to the angio suite and pull the clot out. However, there were subsequent studies done in Japan, Europe, and Canada that failed to establish this finding that was found in China, and indicated that there were still potential benefits from combining the therapies, and that it actually achieved a higher reperfusion rate when you gave someone alteplase first and then pull the clot out. Which kind of makes sense to me. You're giving something that's going to cause clot breakdown, and then you go in and you help pull the clot out with a device. It's probably easier to open up more of that territory past the occlusion. Mr. Clean, No IV, and Direct Safe were also 2 studies that show that in Asian populations with combined therapy, so with both giving alteplase and then followed by thrombectomy, those patients had a better modified ranking. So now there are like these mixed trials, but it seems they're more leaning towards, more trials are actually leaning towards giving alteplase or tenecteplase and then still going to the angio suite and not skipping giving this medication and going straight to pull the clot out. So there's still trials ongoing. There's the Bridge TNK trial that actually is going to look at tenecteplase because all of the rest looked at alteplase. With EVT, with endovascular thrombectomy versus thrombectomy alone. So for now, this is kind of a take-home. Even at our thrombectomy centers, if someone goes straight to the thrombectomy center, they are within the, time frame to receive alteplase or tenecteplase, we give it, and then we go straight to the angiogram suite for neuroendovascular surgeons to do what they do. So our aspect score, I think everyone pretty much knows. Aspects is a score that ranges from 10 to 0, with 10 being good, 0 being bad, and then we just subtract. We look at our CT scan, we see if it looks like there's a hypodensity in any of these regions of the brain, the caudate, the lentiform nucleus, the internal capsule, the insula, various regions of our MCA territory, and we subtract 1 point for ischemia. So 10 would be normal, and 0 means extensive ischemia. Most of the endovascular thrombectomy trials excluded patients that had large strokes, which was an aspects less than 5, or a stroke that was greater than 70 milliliters, due to poor outcomes and higher risk. So these patients were not even included in these trials. There was a trial in Japan called Rescue Japan that enrolled patients. Their question was, should we do this in patients who have larger strokes that we can already see on CT scan? Should we take them to the angio suite? Should we remove the clot from their millocerebral arteries? This study actually enrolled patients that had an aspect of 3 to 5. Which most people would say that's a very large stroke. You can already see it on CT scan. But they were able to show that there was significant improvement in their 90-day modified ranking scale scores in patients who underwent thrombectomy compared to those that only got standard medical management, which typically for this patient population means they're not getting TPA and they're not getting a thrombectomy. They did find that this is the major concern, right? When you have all of this dying brain tissue, you pull that clot out, you have reperfusion injury, and then you create intracerebral hemorrhage. They did find that overall intracerebral hemorrhage rates were higher in the thrombectomy group. However, symptomatic hemorrhage, which is something that you're concerned about, leading to actual decline of the patient, not just found incidentally on imaging, but actually, changing that patient's course, did not differ significantly. Secondary analysis of this study actually found that benefits were most pronounced in patients who had an aspects of 4 or 5. 2 other trials, SELECT-2 and ANGEL aspect, focused on patients who also had a lower aspect score, meaning a larger core infarct, and they also showed significant benefits with proceeding with thrombectomy, even in a large core stroke. And there was actually early termination of both trials due to overwhelming evidence of improved outcomes. There are still some ongoing trials, last tension and Tesla, and I guess we'll have more evidence on this in the future. I know that where I work, our neuroendovascular surgeons are very aggressive, and patients who have large strokes do still go to thrombectomy. And we have seen a higher rate of hemorrhage and hemorrhagic transformation after this, but it's not been, at least in my anecdotal experience, it's not been significant enough that I think it has really led to a decline or change. So we are still moving forward with intervening on large core stroke infarcts with thrombectomy. So all of these recent studies kind of challenge, who should not get a thrombectomy, and there's ongoing research coming. I think all of the recommendations will continue to change, will continue to evolve, and as there's more data, the American Heart Association, the American Stroke Association will probably start recommending that we do this procedure more and more on patients that have been previously excluded. How about tandem occlusions? So a tandem occlusion is where you have, your anterior circulation large vessel occluded, like your MCA, and you also have a high-grade stenosis or occlusion of the ipsilateral carotid artery. We often see this in patients who have a carotid dissection or severe atherosclerosis, and it occurs in approximately 10 to 20% of acute ischemic stroke cases. And the optimal treatment strategy for this has been nebulous. Patients who have, high-grade stenosis and also large vessel occlusion of their MCA, those patients may need a carotid stent. And the question has always been, when should we place this carotid stent? We're already inside the vessel. Should we go ahead and place the carotid stent right now or not? Should we wait? And a lot of centers have done this differently. This just highlights a tandem occlusion. Here you have a right M1 occlusion, and here you have signs of a carotid dissection, kind of like the flame sign. So this is a tandem occlusion in a patient. There was the ESCAPE NA1 trial that showed that if in patients who had an occlusion of the carotid in addition to an occlusion of the MCA, this did not affect the likelihood of achieving a good outcome after thrombectomy. But they did note that there were limitations, including, collateral flow in different patients, and also smaller infarcts among enrolled patients, and suggested that further investigation was needed. In terms of acute carotid stent placement, there was a study, it was a meta-analysis actually by Dufert that showed that placing a carotid stent while you were doing a thrombectomy did not increase mortality and did not increase intracranial hemorrhage. I will say that as an intensivist, sometimes I am hesitant when that occurs, like when our neuroendovascular surgeons place a stent as they have pulled the clot out, because this study looks at intracranial hemorrhage and mortality, but there are other effects, because once you have a stent, you need to have like your antithrombotics on board, your aspirin and annuplavates. Some of these patients do have very large strokes and can increase, even though there's no symptomatic increase in intracranial hemorrhage. There's other stuff that I worry about as an intensivist, which would be, does the patient need a tracheostomy? Does the patient need a feeding tube placement? And once they're on Plavix, it is hard to coordinate, those surgical procedures that they may need. And then I have found that it sometimes leads to increased length of stay. So it will, so I think future studies should look also at length of stay in the hospital, because when we're stenting these patients with these large strokes and then they need a feeding tube placed, it can be tricky in terms of like holding their Plavix, making sure the stent doesn't reocclude, et cetera. So how about in the posterior circulation? Posterior circulation strokes, including basilar artery occlusions, represent 7 to 12% of all intracranial large vessel occlusions. As we know, a basilar artery occlusion is not a good thing, and up to 80% of patients, with moderate to severe deficits actually die or just have severe disability despite standard medical management. And the major causes of a basilar artery occlusion are large atherosclerosis in the basilar artery itself or cardioembolism. There's been a lot of challenges in figuring out, what to do and the best treatment approach for patients who have had a basilar artery occlusion. For example, the BEST trial was actually just discontinued. This was a trial trying to figure this out due to poor recruitment and also high crossover rates, which makes sense. Basilar artery occlusions do happen, but not as often as other occlusions. And then also when a patient is deteriorating in front of you, you feel like you have to do something. So patients were not really in the groups they were supposed to be in, which was like standard medical management, versus thrombectomy. The BASICS trial actually failed to show a significant benefit of thrombectomy over standard medical management, but they thought it was possibly affected by non-consecutive enrollment, and then also our treatment bias, as I already mentioned, as clinicians and physicians, because when someone's deteriorating in front of you, you want to do something, and you feel like, hey, I should just go and pull the clot out and see what happens. There were positive outcomes in recent studies. These two trials done in China demonstrated improved outcomes in patients who had thrombectomy for basilar artery occlusions within specific time windows. The notable take-home from these trials was that they use a posterior circulation aspect as an exclusion criteria, emphasizing the importance of careful patient selection. So a lot of people don't really know the posterior circulation aspects, but if these trials pan out, it is something that we probably will have to start learning and using ourselves. And it is an adaptation of the aspects, but it's specifically designed for the posterior circulation of the brain. And this is how we deduct it. So it also starts with a score of 10, and then 1 point is deducted for ischemic changes in each of the following areas. So you look at your left or your right thalamus, the left or right cerebellum, the left or right PCA territory, and you subtract a point. So just from this alone, you could subtract 6 points. And then 2 points are deducted for ischemic changes observed in kind of, what we think are like the more important in terms of prognosis and outcome regions affected in the posterior circulation, which would be your midbrain and your pons. So a score of 10 indicates no visible ischemic changes on CT scan, and a lower score indicates more extensive ischemic damage. So the takeaway from these trials really is that I think most of our neuroendovascular surgeons and interventional neurologists, are taking these patients to thrombectomy as long as it looks as though there's enough of your posterior circulation to save, knowing that there is a high mortality and morbidity if we do nothing. How about imaging? So with all of these trials and their imaging inclusion and exclusion criteria, imaging has become a lot more important and is actually becoming, it's listed on our protocols when patients present to the hospital. So the American Heart Association and American Stroke Association has actually included imaging guidelines now for patients with acute ischemic stroke. We all know that we've always been doing immediate brain imaging, non-contrast CT. If you're at a really fancy place, an MRI as they roll through the door can be done. I don't know many places that do that. We actually did that in Miami. We would take patients straight to MRI, which was impressive. Non-contrast CT and MR imaging is important because when a patient presents in front of you, which I'm sure Dr. Kaufman will discuss shortly, and they have a right hemiparesis and hemisensory loss, you don't know if it's an ischemic stroke or if it's an intracerebral hemorrhage. So you need to do a non-contrast CT or MR, but 99% of places do non-contrast CTs before giving your TPA or your tenecteplase. For patients who have a stroke within 6 to 24 hours, and you want to know if there are candidates still for thrombectomy, they recommend that we use CTA with CT perfusion or MRA with DWI. And that should be done within that time window, kind of stat actually too, while they're in the emergency room. And then intracranial and extracranial vascular imaging is recommended. We kind of do it for all patients. So we get a CT angiogram of the head and neck because we want to know, is there a large vessel occlusion? Should we be calling our neuroendovascular surgeons? And then also the extracranial imaging is important because it can help them also with their planning for the angiogram suite. So what typically happens now is, a patient presents to a hospital that's like an hour away from my main hospital, which is a comprehensive stroke center, but it's a primary stroke center. So the patient goes to a primary stroke center that's like an hour away from our hospital. They get the CT scan done. If the CT scan does not show hemorrhage, they are within the window for the administration of tenecteplase or alteplase. They get either, but now it's tenecteplase at any of our outside hospitals. And then the patient goes immediately back to the CT scanner for a CT angiogram to look to see if there is a large vessel occlusion. If there is a large vessel occlusion, then our neuroendovascular surgeon is contacted. This is all done on an app, actually. We have an app that has the images pulled up, so it's all under one patient on their phones, and they can see the CT perfusion. They can see how much territory there is, to save or not, and how large the core stroke already is. Then the patient is flown to our hospital via helicopter. We have a helipad on our roof, and is taken immediately. So does not go to the emergency room, does not go to like us in the neuro ICU, but goes immediately to the angiogram suite where the clot is removed and then comes up to the neuro ICU. Okay, so I'm just going to do a brief case. So this is a 55-year-old man. He presents to the emergency room with left hemiparesis and hemisensory loss. His NIH stroke skill score is 18. What questions should you ask? What do you want to know? Yeah. Blood pressure? Okay. So you want to know. Yeah, so important things, last known dwell time. Yes, so you want to know if the patient is within a window to do anything, right? If it was, time is brain, right? So, and we can act within 24 hours. So, if they've been home for 3 days and no one's heard from them, and then someone went to check on them because they didn't hear from their grandmother for 3 days, then, there's very little that we can do. What else do you want to know? Medications are important, right? Blood pressure. Why do you want to know the blood pressure?
Because if it is higher than 220,
Yeah. So you want to go over your indications for thrombolytics, including your medications. This is always a tricky question, I guess. So sometimes we send labs, right? Because they're like INR cutoffs, et cetera. Would you wait for, say you're sending out an INR and it's going to take an hour to come back, do you need to wait for it? No. Okay, great. So you want to know last known dwell time, you want to know your relevant medical history, right? And then also what medications the patient's on. This is a CT head, and you are at one of my hospitals where we give tenecteplase. And the nurse has the tenecteplase box ready. So in our emergency rooms, we have a tenecteplase box, right? That is in the emergency room and it's labeled stroke. The important thing in labeling stroke is tenecteplase has been used and is currently still used in like STEMI patients, right, in the cardiac world, and the dosing is different for stroke compared to cardiac patients. So recently there was because I do like quality for our hospital, there was a case where the wrong dose was given because the nurse pulled the myocardial infarction box and not the stroke box. But the myocardial infarction dose is a lot higher, and there are no bad patient outcomes, so all's well that ends well. But would you say yes to tenecteplase here? So the patient's not on, the blood pressure is good, not on any anticoagulants. Yes, right? Yeah. All right, so tenecteplase is given, what do you do next? CT angio, yeah. So CT angio, but do you want to do a perfusion study or no? Yes. Okay. All right, so you do both. This is CT angiogram, and this is pretty obvious. I'll just ask the residents in the room, not the attendings. For the residents, what do you see? In the back, go ahead. Yeah. Which side? Right, yeah. You would be amazed how many times, like, we see stroke patients every day, but then I read my note and I go, oh, I meant left, not right, not left. Yeah. All right, so this is the CT perfusion. And maybe for a resident as well, what do you see from this CT perfusion? There's a mismatch. Okay, and how large is the core infarct? Do you know? Like which? Okay, so this is right here. So we look at our cerebral blood flow volume, less than 30%, as a measure for what the core infarct is that has already occurred. And this is 67 cc's. But then on this side, you can see that there is a large territory of brain that has reduced blood flow. So if we do nothing, this would become the size of the stroke. And this right now is the present size of the stroke. So based on this, our neuroendovascular surgeon was contacted. This is actually like one of our patients that I saw recently. And you can see here on angiogram, there's an occlusion, abrupt cutoff, right, of our middle cerebral artery. This is the wire inside the brain to pull the clot out. This is reperfusion after. And then this is the clot that was pulled out. Okay. So this has really led to the stroke workflow that's pretty much used everywhere where there are time cutoffs. And actually, in our hospitals, in order to be a comprehensive stroke center, you need to meet these time cutoffs when patients present to the hospital with an acute ischemic stroke, or not, you can lose your accreditation as a comprehensive stroke center or as a primary stroke center. So they really hold you accountable to doing everything in a timely fashion. So if a patient presents and there's a possible stroke less than 24 hours, our hospital has a less than 20-minute window to get a non-contrast head CT from hitting the emergency room door. If that shows a bleed, then this is Dr. Kaufman's talk, not mine. If there is no bleed, and it's within that 4.5-hour window, you give your thrombolytic, and then you take the patient back to a CTA. There are some hospitals, so when I was in Boston at Mass General, patients, because Mass General is just a different kind of hospital that I have ever experienced, meaning, the top of the top. Patients would get CTs and CTAs at the same time. So they just go to the CT scanner, there's no back and forth. But there are some hospitals where, that actually creates delays. So for, especially our smaller hospitals, we don't do this because they need a tech, they need to have good IV access, a lot of things need to happen, and it was causing delays in our CTAs. So patients get CT scans first, and then the drug is given, and then we can worry about looking to see if the vessel is occluded. If there is no large vessel occlusion, the patients get admitted often to us in the near ICU for post TPA or tenecteplase care. If there is a large vessel occlusion, CT perfusion is typically ordered at the same time. We don't order a CTA and then a CTP, we just order both. This other pathway really is, is there a large vessel occlusion or not? You can just follow these arrows. Based on all of the advances in stroke care, as much as we have advanced stroke care, ischemic stroke care in the last decade, really since 2015 and Mr. Clean, the most important thing really still is getting patients to the hospital quickly, right, and educating the public. Because we all know that we have patients who present to the hospital days after stroke symptoms, and then there's nothing that we can do for them. So the most important thing is really starting with the basics, which is education. And then also, I know a lot of countries in the world, I'm from Barbados, which is kind of like the Dominican Republic in a way where we do not have, like an emergency medical system that's robust and just picks patients up and takes them straight to the hospital. But you need to have like a good emergency medical system that will, when they are called to that patient's house or work, wherever, will take the patient to a place where they can receive the best care. Stroke order sets are very important because it standardizes care across all of the hospitals according to the American Heart Association, American Stroke Association guidelines. So one of the factors when our hospitals are evaluated by these accreditation committees is they look at our order sets and make sure that we have an order set for stroke, and that order set includes everything that the American Heart Association recommends. So these order sets often include our vital signs, our NIH stroke skills scores, our CT scans, our MRIs, imaging protocols are all in the order set, and they're kind of like check boxes that are automatically checked. We often have to uncheck them so that they're not done. And then also we have order sets for IV TPA and for tenecteplase, given that there are things that you need to do after administering these drugs, right? You need to monitor for signs of bleeding, blood pressure goals change, all of that is within the order set. There is a mechanical thrombectomy order set at our hospital too, because I didn't go into it in this talk, but there are a lot of studies that have shown blood pressure goals after thrombectomy can also be important in terms of functional outcome, and there are different blood pressure goals for different TICI grades, which I never remember myself, but it's already in the order set, so that is automatically done by our nursing staff. And then also secondary prevention is important. So all of our order sets will have, our aspirin recommendations or atorvastatin recommendations, and then also we'll have education, like if there's diabetes, like a diabetes educator has to come talk to the patient, and then of course physical therapy and case management consults are all part of our order set, and this is trying to improve stroke care. Not only on the acute side, but making sure that secondary prevention measures are employed, and then also helping patients with rehab and resources that they need after stroke. So this just shows the importance of stroke order sets, and there are a lot of people that are involved in stroke care. It's not just us as neurologists, but our nurses, our diabetes educators, or we actually have a specific stroke coordinator whose job is just to make sure that everything is ordered that should be ordered for every single one of our stroke patients. And that is it. And this is just a picture of a room in our hospital where I work. Yeah? Okay. All right.